Καλησπέρα κυρίες και κύριοι και τηλεθεατές και φίλοι της εκπομπής Θέματα Υγείας. Συνεχίζουμε για δεύτερη Κυριακή με μια εξαιρετική προσκεκλημένη, την καθηγήτρια Δρ Ελένη Παλαζίδου. Όσοι μπορέσετε να μας δείτε την προηγούμενη εβδομάδα, μιλήσαμε ιδιαιτέρως για ένα πολύ σοβαρό θέμα και λεπτό ζήτημα, για το θέμα της κατάθλιψης. Ήταν τόσο πολλά να πούμε που σίγουρα δεν καλύπτονται σε μια εκπομπή. Κυρία Παλαζίδου, ως εξαιρετική καθηγήτρια ψυχιατρικής, θα μας αφιερώσει από το χρόνο της και θα κάνουμε κάποια sequel εκπομπών και θα μιλήσουμε για διάφορα ψυχιατρικά νοσήματα. Σήμερα, στο δεύτερο μέρος, θα μιλήσουμε για τη διπολική διαταραχή και για τις αγχώδεις διαταραχές, κρίσεις πανικού και διάφορα συναφή που συμβαίνουν ιδιαιτέρως συχνά γύρω μας. Θα ξαναπώ λίγα πράγματα για την Δρ Παλαζίδου. Γεννήθηκε στην Κύπρο, μεγάλωσε εκεί, πήγε στο σχολείο Θηλαίων της Λευκωσίας, σπούδασε ιατρική στη Σόφια και κατόπιν ήρθε στην Αγγλία και έκανε ειδικότητα ψυχιατρική στο Maudsley Hospital και στο Ινστιτούτο Ψυχιατρικής του Λονδίνου. Είναι ειδικός ψυχίατρος ενηλίκων, ήταν consultant, δηλαδή διευθύντρια στο NHS πάνω από 20 χρόνια και τώρα είναι ανεξάρτητη, δουλεύει ως ιδιώτης. Έχει κάνει έρευνα και διδάσκει ως καθηγήτρια τόσο στην Αγγλία όσο και στην Κύπρο. Στην Αγγλία έχει κάνει πάρα πολύ έρευνα και διδάσκει στο Barts και the London School of Medicine στο Queen Mary University. Στην Κύπρο δουλεύει στο St. George's Medical School στο Πανεπιστήμιο της Λευκωσίας. Εργάζεται με μια ιδιαίτερη ομάδα με Σομαλούς και έχει πάει και στη Σομαλία. Είναι μια ιδιαίτερη ομάδα ανθρώπων, τους οποίους έχει μελετήσει ιδιαιτέρως. Είναι πρόεδρος της Ελληνικής Ψυχιατρικής Εταιρείας στην Αγγλία, με πάρα πολλές σημαντικές εκδηλώσεις. Είναι πρόεδρος της Ένωσης Κυπρίων Αγγλίας και πρόεδρος σε πάρα πολλές άλλες ενώσεις. Ένα εξαιρετικό βιογραφικό που περιλαμβάνει έρευνα, δημοσιεύσεις, συγγραφή βιβλίων. Και έχει ένα ιδιαίτερο ενδιαφέρον, έχει επικεντρώσει την έρευνά της στην κατάθλιψη, στις διπολικές διαταραχές και στην ψυχοφαρμακολογία. Καλώς ήρθατε και πάλι.
Ευχαριστώ.
Είναι μεγάλη χαρά για μας και τιμή. Και σήμερα θα σας ακούσουμε για τις διπολικές διαταραχές και για τις αγχώδεις διαταραχές. Και νομίζω ότι θα έχουν την ίδια αξία και το ίδιο ενδιαφέρον για τους ακροατές μας όσο έχει και η κατάθλιψη.
Ελπίζω.
Ας ξεκινήσουμε τη διπολική διαταραχή. Όπως είπα και στην προηγούμενη μας εκπομπή, κυρία Παλαζίδου δουλεύει πάρα πολλά χρόνια εδώ, οπότε ίσως είναι πολύ πιο εύκολο να μιλάει στα αγγλικά παρά στα ελληνικά. Λέμε διάμεσα και κάτι ελληνικά, αλλά η ορολογία και η έκφραση όσον αφορά το επιστημονικό της κομμάτι της είναι λίγο πιο εύκολο στα αγγλικά. Οπότε σας δίνω το λόγο να εκφραστείτε όπως εσείς αισθάνεστε καλύτερα.
Ναι, αν είναι δυνατόν να μιλήσω στα αγγλικά για τους λόγους που εξηγήσατε, αλλά επίσης και για να μπορούν να καταλαβαίνουν και οι πιο νέοι που έχουν μεγαλώσει εδώ και η αγγλική είναι πρώτη τους γλώσσα. Στην προηγούμενη εκπομπή είχαμε μιλήσει για την κατάθλιψη. Σήμερα θα καλύψουμε τη διπολική διαταραχή. Ένα μεγάλο κομμάτι της διπολικής διαταραχής είναι κατάθλιψη. Τώρα να αλλάξω στα αγγλικά. Bipolar disorder is a condition that presents with two different states. The people affected sometimes can go through periods of feeling depressed, have a presentation of a depressive illness, and at other times they go into a manic state. And I'm going to, I have already explained the depressive state, and I will explain later what the manic state is about. But also to mention that sometimes people may have a mixture of the two, which then makes the picture more complex and it's difficult for the doctor sometimes if they see the person for the first time to sort out what is happening. Now, in bipolar disorder, perhaps I should mention that what we call unipolar disorder, that is depressive disorder without manic states, tends to be more common in women. In women during their reproductive period. In children and in older people, there's no difference in the incidence of depression between men and women. But during that period, the reproductive period of women, there is an increased risk. to the extent that women outnumber men 2 to 1.
Is it related to hormones?
It's possibly related to hormones, psychosocial stress, and obviously pregnancy, childbirth, which make women more vulnerable to becoming unwell, mentally unwell. Now, going to bipolar disorder, bipolar disorder, as I explained, presents with discrete episodes of depression or mania. Now, the depressed state is exactly the same as it is in unipolar disorder.
Okay.
So if you, for example, as a general practitioner, if you see somebody for the first time with no previous history presenting with a depressive episode, you won't know whether in the long run they will have bipolar or unipolar disorder.
Indeed.
But it is always important to ask whether they had periods of depression or of mania in the past, because the treatment then of the depression will be different. And we'll come to treatment later.
Okay.
Perhaps.
Yeah, definitely. But that's not something we can treat in primary care.
No. You had asked me before when we talked about depression, when to refer to secondary care. And of course, it depends which country you're in. But in the UK, the system is such that doctors in primary care are mainly responsible for treating straightforward depressive disorders. So they will give antidepressants or they refer for psychological treatment, and they will manage that episode. Now, if the patient does not respond adequately to treatment, or if there is concern about suicidal risk, or if the picture is very complex, or if they have bipolar disorder, then they should be referred to a psychiatrist, to the specialist services.
Definitely.
Now, if a patient presents with depression, a general practitioner will always ask whether they had at any time in the past a manic episode, and if they did, then they should see a psychiatrist for a plan of treatment. Now, a manic episode, how does that present? It's the opposite of depressed state. Essentially, people feel over the top happy. They feel they have all the psychological and physiological changes that we talked about before, but in a different way. So, for example, in terms of psychological changes, how they see themselves, their self-esteem is very high. They sometimes can become grandiose, and they may even develop delusions of grandiosity that they're extremely successly and they have special gifts, they're celebrities or whatever.
Exactly.
But even if it doesn't reach that state, certainly at a milder level, people still feel really very good and over the top, happy and confident in themselves, much more than they would normally feel. They also feel full of energy, so they are constantly on the go, they are overactive, and they need less sleep. So while in depression people are desperate to sleep but they can't sleep, in a manic state people do not sleep but they don't feel they need the sleep. So they feel full of energy and they can be up all night, I don't know, cleaning the house, dancing or doing things because they don't feel the need to sleep. They have lots of plans. So their concentration, like in depression, is poor, but in a different way, in that in their mind there's a succession of thoughts and ideas and plans. And sometimes this can be so fast that it reflects itself in the way people speak. They can speak very fast and it's difficult to interrupt them. And they can jump from one subject to another because these thoughts are going in rapid succession in their brain. Despite all the plans though and all the ideas, these never get to fruition, so they never finish a task. They start with something, they go on to something else. So these are the sort of typical presentations. Also in terms of their appearance, they may be more flamboyant in their appearance. They may be disinhibited in their behavior. They may be over-familiar with people.
Shameless sometimes.
Yes, they lose the sense of modesty and yes, they may talk to total strangers. They may even get into more difficult situations or like becoming more promiscuous because they're more reckless in their behavior. They have less control over their behavior. They're more exuberant and their judgment gets impaired as a result. So it can really lead to difficult situations. They may drive very fast, they may get involved into dangerous activities and harm themselves. And they may get into conflict with other people because they're very fast in their thinking and they become intolerant of other people. They see everybody as slower and they get irritable.
Can they be aggressive?
It's not typical to be aggressive, but because of the reasons I mentioned, they become intolerant and frustrated with other people. They may be, yes, they may appear to be aggressive.
And diagnostic criteria, is that mainly on symptoms, or is there anything else, any other clinical tools which help you put the diagnosis or establish a diagnosis?
Yeah, the diagnostic criteria, like with depression, are all these symptoms that I described, obviously assessed critically by somebody with experience.
Of course.
And to establish whether they are present or not. And obviously this has to be a change from their normal. So if somebody who's normally a shy, quiet person suddenly starts talking very fast and they are very friendly and they don't sleep and they get involved in sort of activities that they normally wouldn't dream of, all that should alert somebody that they may be
cognitive behavioral therapy, would it be helpful or beneficial in this case or not really?
Less so than in depressive disorder, but in milder forms it can be beneficial, and particularly after recovering, say, from a manic state. In somebody with bipolar disorder, it is good to have a course of cognitive behavioral therapy because it helps people notice the first signs of illness and try and exert some control before they get out of control, or to seek help before.
That's good. And any general guidelines for treatment? Do you want to mention any specific type of treatments which could be helpful?
Yes. As I mentioned before, it is important when we see somebody presenting with a depressive state to try and establish whether this is in the context of a bipolar disorder or not. And the reason for this is not just because we're obsessional and want to make sure we've got the right diagnosis, which is a good thing to do, but also because the treatment needs to be different. If we give antidepressant drugs in somebody who has bipolar disorder, we may trigger off a manic episode. And then we may do what we call accelerate the cycle, so they go from a manic to depressive and manic and depressive, and then we have a rapid succession of manic and depressive states, which is very uncomfortable for the patient.
How can you change from one state to the other? How often?
It can be very quick. Yeah. In some people, I mean, bipolar disorder, the nature of bipolar disorder is that they do change from one state to another. And that can happen. In some people, there may be a period of depression, then a period of many months of a normal state, and then a period of a few weeks of mania, and then normality. In other people, you may have a depressive state and then switch quickly into a manic state without going into normal state and back. So it varies from person to person, and in some people the periods of illness are longer, or the periods of normality are longer, and in other patients they're shorter. So each patient has a different course of illness, essentially. But with the antidepressants, we may accelerate this course. And that is a bad thing, because that's the accelerated form of bipolar depression, what we call rapid cycling bipolar disorder, is more difficult to control. So ideally we try to avoid getting into that state. I mean, some people have it anyway. It's not the antidepressants that cause it all the time, but the antidepressants can encourage it.
So you prefer antipsychotics?
So if we have somebody in a depressed state that we know they have bipolar disorder, then we would prefer other medications. And one of the first choices is a drug called quetiapine, which is an antipsychotic, but it has been demonstrated in a number of research studies that it is effective in bipolar depressed state. And it will not encourage manic state because it will also treat the manic state. It can be used for the treatment of manic state.
Yeah.
Other drugs would be what we call mood stabilizers like lithium, valproate, lamotrigine.
But these ones have the difficulty that you need to check levels and do blood tests about toxicity.
Yeah, with lithium definitely you have to do blood levels to ensure.
ECG.
Lithium is the gold standard for bipolar disorder. Is the most effective treatment. And people don't like it because obviously it needs the monitoring.
Exactly.
There need to be regular blood tests.
ECGs, they have QT prolongation sometimes.
ECG, ECG once a year would be enough,
you're
certainly before starting treatment. The blood levels is a key thing which needs to be done according to the guidelines that NICE, the state Department of Health guidelines. 3 monthly, and then 6 monthly we check the kidney function, which can be affected, and once a year the thyroid function.
Okay.
But people get used to that, and they don't mind the 3 monthly tests.
They're lifelong treatments, I suppose.
As long as they stay on lithium, they have to have the levels done. Yes. But the other medications don't necessarily need regular blood tests for monitoring, like valproate, for example. You need the occasional blood test, obviously, but not at such regular intervals. Carbamazepine also needs a blood test, but again, not so frequent intervals.
Yeah.
So lithium is the only one, but as I said before, lithium is the best. And there is increasing evidence that lithium is the best in terms of reducing suicidal risk in the long run, which is very high in depression, and also in bipolar disorder is very high.
Very good.
So
those
it
are
is
very
worth,
important information.
Yeah.
Okay.
I mean, the study I'm involved now, I don't know whether you could mention that.
Yeah, of course, why not?
We are trying to develop a gadget that will measure lithium without having this blood test. So through the
more practical.
The skin, but I don't know whether it will work. We are still working on it. So we'll see.
That's what research is for.
Yeah.
Wonderful. So you told us quite a few interesting things about bipolar disorder. If you don't have anything else to add, I would like to move on to anxiety and panic attacks and these kind of disorders.
Yes.
Which actually extremely very common.
They are much more
also
common. Yes, they are the most common conditions. Perhaps I should mention before we go on to the anxiety disorders that anxiety is very common both in depression and in bipolar disorder. So they're often what we say called comorbid. They're present at the same time.
Many children suffer from anxiety. We see a lot of
many
kids.
children, adults, old people. It's a very common condition of all ages, unfortunately. And it can present in different ways in different people. The common presentations are what we call generalized anxiety disorder, which means that the person feels on edge, tense most of the time. And sometimes it can be quite severe, even get into a panic state. And I'll explain what the panic state is in a minute. Some people may present with what we call panic disorder, which means they have discrete panic episodes, but they don't have the anxiety outside those periods. So they just, for no reason, they can have a panic attack. And other people may have what we call phobic disorders, which means in particular situations in which they feel uncomfortable, they get very anxious.
Agoraphobia?
And they can have a panic state. So the most common one is agoraphobia, which obviously from the Greek, for our Greek listeners, agora is being in open spaces with lots of people, or being in public transport, or
the lift?
Or being in a lift is more claustrophobia, claustrophobia, being in an enclosed environment. Yeah.
But sometimes some people get in the lift with many people and you see them very agitated.
Yeah, the presence of other, yes. So somebody who doesn't have claustrophobia, if they're alone in the lift, they're okay. But if the lift is crowded, then that is agoraphobia. Absolutely, you're right.
I say that, excuse me, because you know in tube stations here like Queensway, you have some big lifts when 15-20 people can fit in at least, and you see some people become very anxious, they sweat, they push in, you look at them, they're very anxious because they don't like the feeling that they're stuck in a place with other people.
Yes. And it's a senseless fear. People recognize they shouldn't feel like that. There's no danger. They recognize there's no danger, but they cannot help it.
They can't control it.
So it's very uncomfortable. And some people may have what we call single phobias. So there may be, the most common ones will be spiders, or snakes, or anything, or having blood samples taken, or cockroaches, or anything. Or flying. I mean, many people cannot use the airplanes because they're scared.
So many people get in panic attacks in the airplane.
Now, a panic attack, I have a lot of patients who come and say to me, I have panic attacks, doctor, but when you ask them what exactly happens, it's just more severe anxiety. A panic attack is a very specific state which consists of two key features. What we call somatic, physical symptoms. They feel that they cannot breathe properly. They cannot catch their breath, and they get very frightened because of that. And the reason is that they breathe frequently in a shallow way, so they don't take
deep breaths, oxygen.
And what happens, because they breathe frequently, the oxygen levels go high in the brain, and that means they get dizzy.
Yes.
And that frightens them even more.
Hyperarismos.
Yeah. They also get what we call palpitations. They are aware of their heart beating, and usually beats fast and really strongly. They have palpitations, tachypalmia. They feel funny feelings in their stomach, or they may even get chest pain and they worry they're having a panic, a heart attack. Often people in a panic attack end up at the accident emergency department thinking they're having a heart attack. And sometimes because of this overbreathing that I described before, and because of the oxygen levels going down, and we get into a state of what we call metabolic alkalosis, so the pH, the acidity of the blood changes. This can cause funny symptoms in the body. So people may get into spasm of the fingers, so they may go like this, what we call tetany. And that is very scary. This is when it's a very severe attack, but it's nothing to worry about. This can go away. They also can get tingling around the mouth or in the fingers and numbness. So all these symptoms are to do with the overbreathing. So the way to control it will be to breathe slowly but deep breaths. So you normalize the acidity of the...
When you see people blowing in a bag...
Or they can blow in a brown bag, so they breathe the same air, so the carbon... what do we call CO2 in Greek?
Μονοξίδιο του άνθρακα.
Διοξίδιο.
Monoxide.
Το διοξίδιο του άνθρακος αυξάνεται και ελαττώνεται το οξυγόνο, οπότε δημιουργείται μια ισορροπία φυσιολογική. Αυτά είναι τα συμπτώματα, τα σωματικά συμπτώματα του πανικού. τα ψυχολογικά συμπτώματα είναι intense fear, ένας τρομερός φόβος ότι κάτι το πολύ σοβαρό θα συμβεί. Heart attack, θα πεθάνουν, δεν ξέρουν τι είναι, αλλά είναι σε ένα τρομερό φόβος τον οποίο δεν μπορούν να ελέγξουν. Οπότε είναι μια πολύ σοβαρή κατάσταση αγχωτικής διαταραχής, the panic attack. The other one that people don't mention very much, and I think it's useful for people to know about this, some people, instead of going into a panic attack when they are very anxious, they go into what we call a dissociative state. So they feel sort of strange. They overbreathe again, and they get this sort of strange feeling of dizziness. But they feel as if their environment is strange. They themselves feel strange. This is not uncommon, but people don't know what is going on, and they don't connect it to anxiety.
Okay.
This is what we call in English derealization. So reality is distorted, it's not quite right. We are in a normal environment, a recognized environment in our kitchen, in our sitting room, and yet it feels strange. Or we ourselves feel strange, so it's sort of depersonalization.
We think we are someone else?
No, but we feel strange. We don't think we are someone else, no, but we feel strange in ourselves, as if we're not quite right.
But it's difficult to...
It's difficult to get to grips with it. Yes, it's difficult to get to grips with it. So people get scared in this state, and then it goes back to normal. So this is again a state of increased extreme anxiety.
I see. That's very interesting. And what do you usually suggest? We have a lot of people who come from Greece, and they used to buy Xanax, and it's not available in UK. So I came to tell you that I want a prescription which is Xanax, and we don't have Xanax in UK. So give me something else. So we would love to hear some suggestions from you how we would treat these anxiety and panic attacks. What would you think? Well, I know, but I would like you a few things, but I would like you to tell me, apart from the things we know and use in primary care, what else we could use?
Yeah. I would like to make a blanket statement that drugs like Xanax or any other drugs with similar action, we call them benzodiazepines, like Valium,
diazepam,
the Librium, diazepam, all these drugs we avoid prescribing. Although they have an immediate effect, and patients like them because they feel okay, they have serious problems with dependence. So if they're used for 2 weeks or more, then the tolerance increases, which means the patient needs to take a higher dose to achieve the same effect.
They become addicted.
And then they get to a point where even the highest dose doesn't work. And I have seen lots of patients like that who are in a desperate state. They cannot stop them because if they do, they get impossible withdrawal symptoms. They are so unpleasant that they cannot stop. So in the UK, we are very strict about this. We do not prescribe either in primary or secondary care more than 2 weeks of medications. There are other medications, but before I come back to medications, I would say that the first choice of treatment should be psychological treatment.
CBT.
Cognitive behavioral therapy, which uses the cognitive approach to try and explain to the patients how the symptoms come about and help them control those symptoms before they become severe enough. And gradually people then get more and more control over those symptoms. And the behavioral element obviously is helpful in, say, agoraphobia, somebody who's housebound because they're too scared to go outside. The behavioral element is to try and get people to put themselves in that situation and gradually put themselves in more and more difficult situations. So somebody with agoraphobia who doesn't even step out of their front door, you would advise them to go stand outside their front door until the anxiety goes down. And if I could explain here that when one is very anxious in a situation that makes them anxious, the anxiety climbs up and up and up and up. Up to a certain point, it cannot go any further.
Yeah.
If we stay with the situation that causes the anxiety, then the anxiety will start going down and will completely go away. So in order to fight it, the best way is to stay in that situation until that anxiety level has dropped down completely, and then go back home.
Okay.
And then the next time, go a bit further and further, and eventually people find, I can do that now. Why was I so worried?
If they can't do it on their own, do you advise them to take someone with them? Because if the situation is beyond control, they will have someone to take them back home?
I think the best way to control it is to do it on their own, because if they rely on somebody else, it will never go away, because there will be that support there.
Not to rely, but maybe just in case.
But, well, in the early stages, maybe, yes, but at some point they have to do it themselves. So they demonstrate to themselves they can do it because they are in control, not because they depend on somebody else. Now, I remember a patient that I saw some years ago. When I first saw her, she said, she was agoraphobic, and she couldn't come out of her house. And she used to live in a busy, the house was on a busy road, and the opposite side of the road, there was a post box. And she said, my ambition is to be able to cross the road and post a letter. And it took her a few months to do that, but I remember she came back to the clinic one day, and she said, Doctor, I've done it. I posted my first letter on my own, and she was so pleased with herself.
An achievement.
And then she was able to go into town and take the bus and go shopping, and things went back to normal.
Okay. Anything else regarding treatment you would like to add?
So the treatment essentially is cognitive behavioral therapy. Now, if we have to, sometimes people require medication as well. As I said before, diazepam-like drugs are out. We don't want to use those. They are very short-term treatment. Other drugs are the drugs we use in depression, the SSRIs, the antidepressant drugs. They're also effective in anxiety, and we can use those for these purposes.
Okay.
Another condition we haven't mentioned, and that people generally put together with anxiety disorders, but it's not exactly the same, is obsessive-compulsive disorder, and maybe we could mention that. That people have obsessive ideas, that ideas come to their head, if I don't do this, something is going to happen to my children or my partner or myself or whatever. And they repeatedly do things. Or if they go out, for example, they have to check that they lock all the windows and the doors, and they check and double check, and they can do that 10, 20, 100 times each time. Or they worry about being contaminated with something, so they keep washing their hands and use bleach, and they can actually damage their skin as a result. Or sometimes people become hoarders. They have difficulty throwing anything away, so they may have piles and piles of useless magazines that they don't use, or tins of used food, or other things. It can actually become a health hazard. So again, this can be treated with cognitive behavioral therapy. And if they need medication, again with the antidepressants that I mentioned before, but usually in higher doses in order to be effective.
Wonderful. Yes. All of these are extremely useful and helpful. I think we would have so many questions to ask. Unfortunately, we never have enough time to discuss about all this. If you don't have anything else to add, we will close this presentation of yours today at this point, and we will looking forward to having you back in the studio very soon to discuss more mental health issues and conditions, psychiatric conditions, of course.
It would be a pleasure. Thank you.
Yeah, that would be extremely useful, and I wish we could have the contact with the viewers to express questions, to ask from their own experience and ask for advice, not kind of consultation, but they might have some practical questions which would be nice to answer, and our response would help other people potentially.
It would be very helpful, yes. I'd be very happy to answer questions if the audience have any. Yeah.
If they can contact us, because we always provide our email and our phone number, so if somebody would wish to ask a few things, and we can list them and present them to you next time, it would be very nice.
Absolutely.
Anyway, it was great having you here. Ευχαριστούμε πάρα πολύ.
Και εγώ ευχαριστώ.
Θα σας ξαναδούμε πολύ σύντομα στο στούντιο. Ευχαριστούμε και εσάς πάρα πολύ όσους μας παρακολουθείτε και μας στηρίζετε, τους φίλους μας κάθε εβδομάδα και προωθείτε τις εκπομπές μας και μου στέλνετε σχόλια και παρατηρήσεις και με ευχαριστεί γιατί είναι μια ευκαιρία να γίνουμε καλύτεροι και να διορθωθούμε. Άλλωστε, όπως έχω πει, δεν είμαστε επαγγελματίες της τηλεόρασης, αλλά προσπαθούμε να βοηθήσουμε κόσμο και αν κρίνω εγώ προσωπικά από τα μηνύματα που παίρνω, ειδικά στο Facebook, που με βομβαρδίζουν από το πρωί ως το βράδυ με ιατρικές ερωτήσεις, τουλάχιστον ξέρω ότι ο κόσμος προσπαθεί να βρει λύσεις στα προβλήματά του και ο σκοπός αυτής της εκπομπής είναι, όταν έχουμε διακεκριμένους επιστήμονες σαν και εσάς, είναι να απαντήσουμε σε κέρια ερωτήματα, να βοηθήσουμε, να τους κατευθύνουμε, να αναζητήσουν τον ειδικό, τον επιστήμονα που μπορεί να τους βοηθήσει και γιατί όχι να βοηθήσουν και εκείνοι με τη σειρά τους άλλους ανθρώπους. Αυτά για σήμερα. Ραντεβού σε μία εβδομάδα και σε λίγες μέρες με ακόμα περισσότερη κυρία Παλαζίδου, η οποία ήταν εξαιρετική και μας διαφώτισε με τις γνώσεις της. Σας ευχαριστούμε. Καλό βράδυ, καλή εβδομάδα.